Good morning. Good to be with you today. And want to just express my gratitude for all of the work that you're doing for the people of Colorado. I also want to acknowledge our Behavioral Health Administration team that is in the building today. We have Maureen Maycheco, our Communications Director. We also have Kristen Laura, our Health Information Technology Director, who is here today. She's going to take all the tough questions at the end. She's waving on the right side. Very good. Well, it's great to be with you, and I really appreciate your mission and vision, which I believe is directly aligned with our calling at the Behavioral Health Administration. If I can have AV just mute this mic at the podium so that there's minimal interference here, or if I need to do that, just let me know. All right. I thought today we'd talk a little bit about behavioral health innovation and how we take a systems approach to achieving population health. Today we're going to really walk through the Behavioral Health Administration's approach to supporting diverse populations across Colorado, and not only their what we typically classify as behavioral health, but their whole person health. We believe at the Behavioral Health Administration that people really deserve to have their social determinants of health addressed, and we are looking at ways to support interconnectivity, data governance, health information exchange, so that indeed that can become a reality. So as you know, Colorado is very unique in that we selected a model in this state which sought to address access to care issues, where we saw that really most Coloradans who needed care reported to us that they couldn't get care in a timely manner. There were delays, that their information was often not synchronized across systems. We learned that individuals at risk of justice involvement or those who became justice involved did not have a unified way of having their behavioral health needs addressed. We learned that there were silos in the housing sector when it comes to behavioral health needs and homelessness. We learned that even those in the private insurance market experience disparities. We learned that we still have not reached parity as a nation when it comes to having equitable access to behavioral health service, irrespective of how one pays for it. And so in Colorado, we sought to address this problem not by consolidating every behavioral health service in one state agency. Instead, we decided that we would appoint a cabinet member, someone who would coordinate and drive cohesiveness, coordination, collaboration across all state agencies that touch whole person health. And in fact, this is the vision of the Behavioral Health Administration. We are a cabinet member-led agency driving coordination and collaboration across all state agencies. It's a really unique model. In fact, as I've talked to leaders across the nation, we are the only state that is attempting this approach to shared governance. We believe it's really important, though, for us to keep at the center of our vision the fact that we are the people's agency. It's really rare to have a state agency that has been called for by the people. And we believe that as stewards of the people's vision, that it's really our responsibility to ensure that we're accountable first to the people of Colorado. I don't know if there's anyone in the room who has served on the Behavioral Health Task Force, but as you will recall, this task force started, it was appointed, commissioned by Governor Polis in 2019, and the task force felt that there were really 6 pillars of transformation for our work. And they gave us these pillars as our foundation, our North Star, if you will. First, we need behavioral health care that can be accessed, irrespective of who you are, your background, your identity, or your experience with a disability. The care has to be accessible. It also has to be affordable. And this is irrespective of how one pays for care, whether public insurance or the private market. We are, of course, extremely concerned nationwide about the behavioral health workforce shortage. And I'm going to say a little bit more about that today and how technology can help us with this pillar. We needed a behavioral health administration that was also accountable to the people of this state. How do people receive recourse when they don't get the care that they deserve? What are our models for achieving behavioral health quality? We learned that a strong behavioral health system and an equitable system has to be built on local guidance. And so we're working with counties, we're working with advocates at the local level, we're working with our Lived Experience Council to help us co-create this system. And we believe in whole person care. In other words, not just thinking about how do we mitigate social risk factors, such as housing and food insecurity and other deep concerns in the social environment, but we think about how do we recreate our policies so that these needs and risk factors are minimized to begin with. And so if we could state our vision, it is really to achieve three things. We want a system that creates care that is accessible, meaningful, and trusted. And at the BHA, we think that our biggest hurdle, our gap to cross, we believe that technology plays a role in this, and that's in building trust. That in order for people to trust our behavioral health system that we are reimagining, that they have to believe that they can get care when they need it, they have to believe that their information is secure, and they have to believe that we are all approaching their care from a people-centered perspective. At the Behavioral Health Administration, we talk a lot about people first, then process, then performance. And Kristen Lara, our Information Technology Director, likes to kind of give a nuance to that. People, process, then technology. I love it. And so we're going to talk a little bit today about how this intersects with our values and how we want to move forward with you to make this system possible. As we completed our brand survey across the state, the people of Colorado selected these 5 values. And these 5 values shape the work that we do across the 6 pillars and with our technology and innovation process. We first understand that the role of technology in the BHA is to center truth. We want to be transparent and accurate as we share data and as we coordinate care for the people of Colorado. We believe that technology also has to uplift equity. Digital equity is something that is important to us in the BHA. We believe it's important to acknowledge root causes of injustice, which in the technology space often is related to inequities in broadband access and other issues. And so we have to allocate the necessary resources to support the desired outcomes. We also uplift community-informed practice, which for us is integrating promising practices from other states and even around the world, and working with our local leaders, such as those in the room, to help us choose the right solutions for Colorado. We are deeply committed to cross-sector collaboration, again, working in partnership to realize a holistic behavioral health vision. And finally, we uplift generational impact, which means engaging in meaningful and thoughtful action in order to create a new legacy for the people of Colorado. We believe that if we are deeply committed to these values, that one day we will see a world in our state where people are no longer saying that they've been harmed by the behavioral health system. They're able to say that because of the work that we've done together and because of how we have innovated and built new technology systems that support whole person health, that people of this state are able to say, because of the work that you do, I'm able to work. I'm able to lead my family. I'm able to be a meaningful and contributing member of society. When we think about our priorities over the next year, I don't know if you're aware, but Behavioral Health Administration's model is that we were established July 1, 2022, and we are at 20% capacity at this time. And really that refers to more of our process capacity, so not necessarily personnel capacity. So what that means is that we're at 20% capacity to really build this cross-sector, cross-system, cross-agency vision. And we hope to be at 100% capacity to have that expansive, boundary-spanning approach by July 1, 2024. So we have 2 years to really build our capacity for cross-systems work. We launched on July 1, 2022. We have achieved a couple of historic milestones, even in the first few months of our existence. We are very proud to have launched the state's first Behavioral Health Administration Advisory Council, which is centered on lived expertise. We have 40% BIPOC representation on that council. We have 50% representation of individuals who are either family members of those with a disability or themselves have experienced a disability. We have over 8 individuals out of 20 who are part of rural Colorado. So it's really a diverse council. For the first time ever, we have a lived experience council that is statewide, that is ethnically and racially diverse, that is guiding the policy decisions of the Behavioral Health Administration. We also, for the first time, launched the Behavioral Health Administration Interagency Cabinet Council. This in itself is historic because we had an opportunity to bring all cabinet-level agencies to the table. We meet once a month and we talk about whole person health. It's pretty amazing. We also have begun the stakeholder process for our Behavioral Health Administrative Service Organization process. As you know, we are seeking to eliminate silos in the state. And so, whereas our old system had a process of sort of splitting individuals by diagnosis, where you went through one door if you had a, quote, mental health issue, you went through another door if you had a substance use issue, and there was yet another door for physical health concerns. We are, in fact, attempting to integrate care by creating a new behavioral health administrative service organization that does not divide mental health and substance use disorder services. And right now, we are engaging in the stakeholder process for the launch of that new policy starting July 1, 2024. We also released our statewide strategy for workforce. And I don't know if anyone's seen that, but that's available on our website, bha.colorado.gov. And the title of that document is Strengthening the Behavioral Health Workforce in Colorado, an Approach to Community Partnership. Really powerful. I'm going to talk a little more about some of the priorities in that document later this morning. The Learning Academy is another incredible opportunity where we are creating a technological space for providers, peer specialists, for those who need care. To join this platform where we can learn about evidence-based approaches to providing care, where we can learn about equity in behavioral health care. We want to uplift topics such as Native American health, understanding the role of spirituality in care, and other key issues that address cultural responsiveness to care. By next January 2023, we hope to release our statewide strategic vision. I'm going to talk a little bit more today about our initial deployment of our access to care methodology. We will be the first state in the nation to achieve something of this magnitude that is cross-payer and cross-sector. Ultimately, when we think about systems change, it's really about people first. And we acknowledge that the old way of doing things, that traditional behavioral health systems generally leave people behind. And generally, it leaves the most marginalized people behind. This system we are envisioning is aiming to put people first. We're seeking to move from a fragmented vision and strategy that's siloed by state agency into a unified vision that is cross-sector, crosses boundaries, and thinks about how do we center the needs of people first. We're seeking to take advantage of the new federal mental health strategy so that we can bring new dollars into the state of Colorado. We're also seeking to uplift opportunities across philanthropy and other sectors as we seek improved funding for this new system. This system will also require a new approach to data sharing and connectivity, and so we are looking at developing a comprehensive cross-agency data strategy so that we can truly have a performance monitoring system that again gets to value. How do we achieve value? High-quality services at lower and reduced cost. We're also looking at creating a radically coordinated system that really achieves what you can see on the screen here, that accessible, meaningful, and trusted care. Again, it gets back to people, process, performance. At the very top of this graph, you will see that as we start with people, we have to decide how we are going to design a system to support population health. The Behavioral Health Administration is also involved in, let me go back. There we go. The Behavioral Health Administration is also involved in redesigning the safety net continuum, ensuring that the people of Colorado have access to services at the intensity that is required and needed in order to achieve whole person health. As we think about the processes that must be supported, our accountability framework, which is built in a process for relying on the Behavioral Health Administration's approach to, again, resolving complaints and grievances when care that is deserved is not received. We also believe in a process of accountability that goes beyond audits, but really thinks through what are the correct data, processes, and measures that lead to an accountable healthcare system. We're also working with our providers across the state to think through how do we bring promising practices, how do we uplift our workforce, how do we provide technical assistance so that indeed we can provide care that's meaningful to the people of our state. And finally, when we look at performance and technology and how this work is supported, we have to think about two issues, quality and payment. The basic tenet of the value equation, in other words, how do we build a high value system, is that value is quality divided by cost. And so we have to think through, what is our quality framework? How do we measure outcomes? What are the data pieces that are meaningful to the people of Colorado? We also have to work with healthcare policy and finance as the largest payer to think through value-based payments and how do we incentivize people-centered care. I want to shift a bit now and show you our initial approach to how do we measure access to equitable care. Well, Governor Polis asked us as the Behavioral Health Administration to address the #1 need of the people of Colorado, which is access to care. When we looked at a national survey of what other states had done in terms of their behavioral health transformation, we learned that really no state had really figured out a methodology to measure access to equitable care that was cross-payer. So this is our attempt to try to do this. We learned from the Urban Institute that certainly there were measures at the provider level that measured access and penetration. We learned that that historic model really didn't include the individual experiences of people in care. So we've added a fourth dimension here. Most quality frameworks include some type of population indicator, a network measure, a provider indicator, but we have added here individual experience and perceptions because we believe in user-centered care and data and technology design as we think about innovation at the BHA. So if we can pull this off, we will be the first state in the nation to have a cross-payer access to equitable care methodology. So let me walk you through this. As we think about care that's meaningful, accessible, and trusted, you will notice that the three columns align actually with each of those words. Care that is meaningful has to be accessible. And so when we talk about the availability of providers, there's 4 metrics that we are looking to measure. At the macro state level, we want to measure how many of Colorado's catchment areas meet criteria of health provider shortage areas. At the network level, we want to look at how many behavioral health providers are available within a network. What is the network adequacy? At the provider level, we want to measure something called the third next available appointment. So not just how quickly can you get the first appointment, but how quickly can you get the follow-up that is so desperately needed. At the individual level of individuals in care, we want to begin measuring health literacy. And so we want to use this measure of how many Coloradans, what % of Coloradans would rate 1 or below on this particular health literacy scale, and how do we begin to move that? If you look in column 2, utilization of services. Again, if services are meaningful, then they should be utilized. So at the state level, we want to begin measuring what is the penetration of behavioral health service types by region. At the network level, we want to look at how often do Coloradans get follow-up after a crisis within 48 hours. At the micro level, for provider, again, we want to look at how many people of those who actually have a behavioral health need actually utilize services. And then finally, at the individual level, how many individuals had a need but got no care. Finally, the third column talks about individual experience. We want to begin measuring how many Coloradans didn't seek care because they were worried about what others would think, a stigma measure. We want to begin looking at the network level about cultural competency. How many people left a doctor's office and felt that their provider understood them? And finally, the Net Promoter Score is what we're recommending as the single metric of success. What percentage of people in our state leave a behavioral health provider's office and say, I would recommend that person to a family member or friend? To drive innovation, we recognize that this work is community-centered. It's people first. For those who have heard me give other talks on technology and our approach to technology, we deeply believe in the BHA that we must relinquish deficit-based thinking, that we have to bring solutions with our community and not to our community. We believe that our communities, in fact, have existed in a system where their strengths may not have been highlighted. And we are really seeking to be a community anchor as we do this work. One of our approaches to community partnership is in strengthening the workforce. We heard across the state that there are not enough providers, period. We also learned that many are not trained in culturally responsive approaches. And we learned that there is a needed model for retaining and recruiting behavioral health providers to the pipeline. And so in our strategic plan, strengthening the behavioral health workforce in Colorado, there are 8 priorities in that plan. We are really highlighting 2 this year. The first that we are highlighting is the need to build a coalition of peer specialists. And so you will see the Behavioral Health Administration working tirelessly this year to ensure that peer specialists are adequately supported in their local communities. We're working with healthcare policy and finance to create new designation types for peer-run organizations so that they, in fact, can also access and bill Medicaid for their services. And the second initiative that we're launching this year is one called a Behavioral Health Aid Program. It actually comes out of Alaska, but it's rooted in a long-standing literature of public health and how we build community health workers to respond to the needs of their own communities. We're hoping to pilot that in Colorado in partnership with the Department of Higher Education. We are also very proud to have built a digital front door for the entire system of care in Colorado. And Kristen Laura and her team have introduced to us Own Path. Again, this system is designed, as our user experienced design group shared with us, to give information that gets you through a bad situation without causing shame. If you've accessed this site, you will notice that, first of all, it's person-centered. When you join the site, you see diverse faces, representation of individuals who hopefully reflect your own experience. It also invites individuals to engage in a guided experience, should they wish. They can also access crisis services from the website. We're hoping to, over time, mature this website so, in fact, it might even be possible to link to telehealth even from this initial encounter. Own Path. We invite you to join the site, take a look at it, and please give us feedback. There's a feedback form at the very bottom of the screen. Thank you. When we think about a people-centered approach to information sharing, we believe that fundamentally it should not be up to the person in crisis or the person in need to recount their entire history, but that our system should support whole person care by having a person's health information available when and how they need it. We desire to be expert partners in building systems that are interconnected. So we're working with healthcare policy and finance and the Office of eHealth Innovation. I don't know if Stephanie is in the building, but that office, HIE, is a critical partner. And again, helping us build on this front door of accessing care to ensuring that we maximize existing technology while building a new future. It's on this side. All right, I'll shift to this side. So, in the beginning, I showed you the accessible, meaningful, and trusted framework. And what you see here in the green bubbles are actually how technology supports this framework. And so if we add our technology pieces, what we're showing here is that for population health, we need an approach to communicating where people can access Own Path and the social health information exchange, whether they have access housing or other services in the community, not just behavioral health. We're creating now an ecosystem that allows the people of Colorado to access behavioral health, that allows providers to talk to one another, that allows us to also have accountability across that system. You'll notice that we're also building a central registry as we think about provider support, a learning academy that again allows us to communicate across providers, across systems, so that we can understand bed availability, bed capacity, and so providers can make referrals to one another on this new platform. On the left-hand side, you will see that in terms of our monitoring and auditing process, we're building technology to support transparent reporting to the people of Colorado on how we are managing and holding facilities accountable for quality care. And then at the bottom of the screen, when it comes to our payment models and our quality framework, you will notice that this now is getting into our interagency governance structure and how we are implementing data sharing agreements with healthcare policy and finance and others in order to ensure that we indeed have a comprehensive approach to people-centered care. As I close, I want to bring us back to our purpose, because we've learned for the last 3.5 years, and really the needs of the people of Colorado have only been exacerbated by the pandemic. We've learned that Colorado needs us now. It's not a choice of when and how to intervene. Colorado needs us in this moment. And so the Behavioral Health Administration is hoping to be a partner with you as we seek to advance this purpose statement. If we really believe that all people in our state deserve whole person health, then let's work together to create a world in which services are accessible, meaningful, and trusted. Let's make it our mission to not just create products, but to co-create a people-first behavioral health system that truly meets the needs of every person in our state. We're looking forward to being a partner as we think about people-first technology. We ask you to hold us accountable as we seek to be stewards of your vision. Finally, the people of this state have asked for a model that acknowledges that nothing can be created for them without them. That innovation on its own will not serve the people of this state. It's really got to be people first. We have to acknowledge their needs first. We then have to establish processes that support people. And then we have to systematize the ways in which people engage in our state process. Thank you so much for being partners with us in this vision, and it's great to be with you today. Thank you.
I do have a few questions here that came through. The first one, as you noted, trust is a critical element in achieving success. What is your perspective on behavioral health areas where there have been historically low levels of trust, and what can we do as a community to improve those levels of trust moving forward?
Should I go back to this? Thank you. All right. So one of the areas that we're particularly concerned about is the crisis system. As many of you know, 988 is a national initiative that is launched across the country, and the notion behind this innovation is that for the first time ever, Americans will have a 3-digit number similar to 911 to access behavioral health care. However, what we also know is that although this is groundbreaking innovation, that many people who are in crisis, in fact, have experienced harm when acknowledging their needs. And so on the day that 988 launched, which was July 16th, the Behavioral Health Administration actually saw and responded to numerous posts on social media by leaders of color who were in fact concerned that people in their community would be harmed by calling 988, that perhaps they would be involuntarily committed to a facility, that their human rights would be violated. So I think that we have a real opportunity in the crisis system, in particular, to address how we support the dignity of people who are in crisis and to be able to see them as people and not merely a problem. And I also think that obviously racial biases have been long documented in terms of people of color are more likely to actually have their rights removed when in mental health care. So we are particularly concerned about how do we reduce stigma when people who are in need, and particularly in crisis, need services and need them to be provided in a people-centered way. So that's one example.
Right. The next one is, what are you doing about the scarcity of mental health referrals for children?
That question I'll need a little more information on, because my understanding is that we have more needs in that system than we can currently address. So I don't know if the question was meant to ask, what are we doing about the needs of children, not necessarily the reduced referrals, but I can certainly reinterpret it question. So we have on our administration a senior advisor for children, youth, and families who is right now helping us address some of the acute needs across the state. We are looking to expand the program, which is called Children and Youth Mental Health Treatment Act, which again helps parents and families who cannot pay for residential care for their child, or who do not want to simply give up custody of their child in order to access meaningful services. So that's one approach that the BHA is taking. We're also making new investments in the Family First Prevention Act program, which again is intended to provide wraparound supports for children, youth, and families. And then a strategy that is holistically addressing the needs of children and youth will be part of our strategic vision that will be released in January. Thank you.
Psychiatrists that take Medicaid are impossible to find in Denver area. Kids go without meds. What will fix that?
A change of heart. You know, most of my colleagues that I went to med school with are frankly practicing in cash-only practices. And so this is a major problem in terms of how do we really begin much earlier in the career pipeline for who we select for medical school and who we select for, again, entering the behavioral health workforce. What are their values? How do we support people that really do have an equity lens to their work? So that's a systemic issue that I think medical education as a whole is going to have to grapple with going forward. Until we can fix that, I think that we are working with healthcare policy and finance on some practical solutions. One of the issues I was actually emailing about this morning is that we want to hopefully work with HICPUF to reduce the amount of time to be credentialed as a Medicaid director or enrolled provider, excuse me, and then also reducing complexities around admin burden and so forth for providers that are part of the Medicaid process. So we are trying to, mitigate some of the paperwork process enrollment that is associated with being a Medicaid enrolled provider.
Are there strategies used in other states or communities that you look to as a model of success, that you look to for possible strategies for Colorado?
You know, I trained in Massachusetts, and I think Massachusetts is really beginning to do some powerful things around system design. Our team recently just met with one of the lead policymakers for the state. And of course, it's a much smaller state, doesn't have the same geographic and population complexity, but we are looking to address some of their system design around specifically their mass health Medicaid services, how they care for high-risk children, and so forth. We also recently met with leaders from Ohio, and their Ohio RISE program is particularly impressive in terms of how they've been able to care for the most vulnerable. Our team is also looking at examples from North Carolina and other states as we seek to partner with healthcare policy and finance on building a complete continuum of care here in Colorado. Thank you.